Dear all, welcome to the 16th edition of TMC Monologue. Today we have another luminary from our college, Dr. Aravinda, a very young and dynamic community medicine associate assistant professor in Tanjore Medical College. And he did his community medicine from AIMS, Bhubaneswar, and he has significantly and meaningfully contributed to school health, non-communicable diseases, and RM and CH. He has been actively involved in biostatistics, training, ethical review, and community-level program implementation. His earlier tenure in Tamil Nadu public health system, ranging from school health medical officer to block medical officer, has given him a deep understanding of ground-level challenges and health system realities. He is a recipient of several awards, including the ICMR Fellowship, UGC JRF, and several Young Scientist and Best Paper Awards. And he continues to contribute to the Hindu and writes quite a lot of commentaries. And he contributes to global collaborations such as Cochrane and the UNICEF Global Health Media Breastfeeding Series. So today it's going to be a very exciting talk, and it is a matter of great concern to all of us. We would all like to know what is the state of the public health of India, what was the past, what is the present, and what is going to be the future. And I think it's appropriate that Dr. Aravinda has been chosen to deliver this lecture, and he has graciously consented and given his time to share his expertise. The floor is yours, Dr. Aravinda. You can go. Go ahead.
Yes, thank you, sir. Thank you for the warm introduction, sir. So, a very good evening to all the participants who have been joined in the Zoom meeting. So, today I will be discussing about public health past, present, and future. So, myself, Dr. Aravinda, I'm an assistant professor. So, today is one of a happy moment for me because though I have not graduated either my UG and PG with Tanjore Medical College, thereby disqualifying me in becoming an alumni of Tanjore Medical College. But I have a very strong and personal association with Tanjore Medical College. So I'm very happy to contribute to this TMC dialogues. So we'll be discussing about the public health past, present, and future. So today I will be discussing, before moving on, I will be explaining what is public health and what are the components of public health and the origins of public health and the difference between the British model and the USA model. Once this has been done, I think it is very easy for me to discuss about the past past of India's public health, the present status of India's public health, and what lies for the future. So before moving on, I just want to drop in a simple question to the audience. When you do a Wikipedia entry for community medicine, it will directly redirect you to public health, and there is no specific Wikipedia entry for community medicine per se. But at the end of the lecture, I will just again allow you a food for thought whether community medicine and public health are one and the same. So now moving on to my presentation. So what is public health? So whether public health is an art or is it a science? So if it is a science that is meticulously grounded in evidence, or is it an art that relies on creativity, human connection to inspire change? And if it is an art, so we can say it is an art because it involves effectively crafting health messages and convincing communities about the importance of, let's say, vaccination program or health, family welfare and family planning, or even a simple thing like promoting hand washing, because these things are core activities of public health, and this requires imaginative storytelling skills, emotional appeal, and persuasive communication skills. And if it is the case, though, then what is the explanation for the following things? Because public health has solid scientific evidence, scientific foundation that is evident from, let's say, germ theory of disease or the modern sewage systems, or even the analytical study of poverty's impact on health, or the demographers doing a census. Now, even if we consider it as a science, what kind of science is it precisely? Whether it is medical science that has strong link to germ theory of disease, or engineering science because the construction of complex sewage systems, or perhaps social science based on because we do study poverty and human behaviors also. So to summarize, actually public health medical science provides knowledge about disease, vaccines, and preventive medicine. And engineering science, as I mentioned, it ensures the infrastructure such as clean water, sanitation, and pollution control, while social science addresses this human behavior. So now, to summarize, public health is harmoniously combining all these various sciences like medicine, engineering, and social sciences through artful communication, thereby advocating social advocacy. So public health is both interdisciplinary and multidisciplinary. It works at the intersection of multiple fields to improve the health and well-being of entire population. Now, whether public health is medicine or it is more than medicine. So public health is not a subdomain of medicine. It is a misconception, and it is a narrow and incomplete view. Public health is both an art and science, and it combines the best of medical science, engineering solutions, and social sciences understanding. Now, coming to the next confused one, whether public health and primary care are synonymous, or whether primary care is a subdomain of public health. Actually, there are a lot of overlapping functions between public health and primary care, but there are significant differences too. So let us see what are the important differences. So when it comes to the level of focus, primary care mostly focuses about the individual patient, whereas public health focuses on community. And primary care, we focus on curative illness, whereas here we focus on prevention, protection, and promotion of health. The typical activities in primary care will include diagnosis, treatment, follow-up, prescription, whereas here it is about vaccination, sanitation, and disease surveillance. The type of health issues covered include minor infections or chronic infections, where we do give follow-up counseling for uncomplicated cases like uncomplicated cases of diabetes, hypertension. Whereas here it will be outbreak control, executing maternal and child health programs, and environmental health. Mostly primary care in all the countries are delivered by general physician, whereas public health, though in some countries it is led by the physician, but it is mostly a team work where public health teams of epidemiologists, entomologists, health administrators do deliver it. And the outcome is mostly relief of symptoms and restoration for individual health, whereas here it is reduction of disease burden in the community or population level. So I have taken this graph from the following study. So as you can see, public health and clinical medicine are two independent domains. At the macro level, we deal about health economics, public health law, trade or public health policies, global or international health, and political economy of health. At the meso level, the health system administration, healthcare financing, and occupational health comes into place. At the micro community level, where you typically see in the primary healthcare centers, we deal about epidemiology, biostatistics, demography, social and behavioral science, public health and nutrition, and public health ethics. Whereas in clinical medicine, it has a very easy classification of primary, secondary, and tertiary care. Now, where does the community medicine specialist stand? Even in India, we community medicine specialists are not properly trained for public health at the macro level, that is state, country, or global level, but we are trained at the meso level, that is organization or district level, to manage it, and micro level, that is managing the block or primary health center and providing a basic clinical services, and MBBS doctor can do it. Whereas a family medicine specialist does not do about the organization or administrative job, but he also does this macro community level up to secondary level. So this is the distinction between public health and clinical medicine. As you can see, there can be a lot of overlap of functions between public health and primary care. Now, what constitutes public health? It constitutes a field of experts from medicine, engineering, social science and statistics, information technology, communication, law, economics, and even politics, delivered by doctors, epidemiologists, environmental scientists, sanitation workers, urban planners. Because if Delhi has been properly planned or Bangalore has been properly planned, we won't be seeing the traffic, noise pollution, or air pollution. Then urban planners, communication experts, data analysts, engineers, paramedics, and climate activists. Now, so the health determinants usually move beyond individual medical care by focusing on preventive health care, environmental sanitation, disease control, health education, and policy making that encompasses community health, occupational safety, behavioral health, and health policy. Now, coming to the origins of public health. As you can see, public health is both ancient and modern. So this is the great Mohenjo-daro bath, and this is the Roman bath. So it is both an ancient as well as modern one. And ancient civilization understood the need for sanitation to prevent diseases. So you can say some aspect of public health was present since antiquity, like the Indus Valley civilization or the Roman civilization. And the modern public health truly began in the late 18th century with industrialization, whereby leading to more number of jobs in the cities, thereby leading to overcrowding, unsanitary conditions, thereby leading to cholera, clostridiums, which are reported widely, leading to the authorities to act upon. And the Britain's landmark Public Health Act 1848 marked the first organized effort to control disease through government policy. And it set the stage for future developments in sanitation and preventive care worldwide. Now, initially, public health revolved around the sanitation, hygiene, and infection control, reflecting the dominant problem during the great sanitary awakening of the 1850s. Over time, this public health has expanded dramatically, encompassing present day food safety, nutrition, occupational health, control of NCDs, sexually transmitted disease, gender equality, poverty alleviation, health disparities, strengthening of the health system, and commercial determinants of health. So, this commercial determinant of health is gaining so much momentum and importance. And if sir allows me for the next cycle, I will be happy to present another lecture wherein these determinants involves the study of aggressive marketing for harmful products which influence health on a population level like tobacco, alcohol, or unhealthy food. So from a simple sanitary ensurement to this level, the public health has traced its evolution in the last 200 years. Now, who delivers public health? Across the globe, the responsibility of public health varies considerably, shaped by historical and administrative structures unique to each country. So, India is influenced by the British colonial past, which I will be discussing in detail in the coming slides. So, the primary function of public health is the responsibility of the state governments, but the central government actively support through funding, planning, and guidelines. Whereas, even though Australia and Canada can be said as former British colonies, yet the public health is at the national level, standardizing health policies across their territories and provinces. And in the United States also, they follow similar to India, where public health is decentralized and managed at the state and local level, with the CDC providing overarching guidelines. But the significant difference is American public health emerged largely from engineering approaches, initially focusing on sanitation and infrastructure. When it comes to Europe, Germany and Switzerland gives autonomy, whereas France and Netherlands have centralized structures, and communist nations like China and Russia have high centralized public health framework with extensive government and surveillance system. Now coming to UK and US model. So before dwelling upon detail into UK and US model, I just want to emphasize that this UK and US model are not competitors or parallels. I can say that this is like Sachin Tendulkar and Virat Kohli. So the American model drew inspiration from British model, and then it developed its own unique thing. But the British model is the one which can be said as the starting point of modern public health one. So it is strongly developed through physician like William Farr, who used mainly for administrative disease control. And here in American one, after they adopted from the British, being a former British colony, they combined the biostatistics and laboratory diagnosis to create a more scientific one. Here in British one, the public health service is predominantly headed by the medical service cadre, that is physician led, whereas here it is a mixed workforce of engineers, chemists, scientists, statisticians, nurses, and city managers. And philosophy here in British one is disease control through clinical administrative governance. Here it is through environmental manipulation, infrastructure, and laboratory science. So it started in 1820s to 1880s. The pillars where the British in their tropical colonies have to face frequent Asiatic cholera epidemics, which resulted in sanitation failure, forced them to create the modern sanitary framework. And John Snow was successful in containing the cholera outbreak without even identifying the Vibrio cholera bacteria or using the microscope, using the modern epidemiological method. And from 1850s, the Paris Sanitary Conference, from where the international health diplomacy started, and it is dominated by medical doctors in Britain, and it is seen as an extension of clinical medicine and centralized and hierarchical. Whereas if you go to American system, which started gaining momentum after the late 1890s, when the germ theory of disease and the discovery of many microbes were done, rapid urbanization and industrialization lead to the historical trigger. Here, the municipality, the engineering departments of municipality took the lead, and it is led by engineers, sanitarians, and bacteriologists. And in USA, it is considered as a separate scientific and technical field, not subordinate to clinical medicine. So it is decentralized, multidisciplinary. The universities based off schools on public health are established in USA. So from 1820s to 60s, the Britain led the global public health effect, followed by the Paris Sanitary Conference, wherein the international health diplomacy was propagated. And by 1850s, after the establishment of field of epidemiology, the Britain led till that point. From there, the USA took on the baton, just like Virat Kohli took on the baton from Sachin. And from 1890s, the American model, with a predominant focus on engineering aspects, started doing this. And by 1915, the Welsh-Ross report, which is formally articulated this American vision. So this is a 300-page report. I have tried to consolidate in a single slide. The conceptual thing is public health should be independent from medicine, not controlled by clinicians. This is American model I am talking about. And the defined schools of public health with core areas of biostatistics, bacteriology, environmental hygiene, epidemiology, and administration. And it is a multidisciplinary workforce with American engineering laboratory model. And this also later influenced the WHO model too. Now, coming to the past of India. So India, this is the Indian subcontinent. The British ruled the present day India, Pakistan, Bangladesh, Bhutan, Nepal, Sri Lanka, all can trace its origin to this British Raj. So I have given the timelines. So I have used the reference of this particular study published in the Indian Journal of Community Medicine. So in the 1764, medical department was created in Bengal. The Calcutta Medical College established in 1835, followed by Madras Medical College and other medical colleges in the provinces. And the Royal Commission on Sanitary State of the Army in India in 1859, after the First War of Independence in 1857, from where the Company Raj to the British Crown was directly ruling. And in 1868, this was the first time they separated the civil medical department from the military medical department. And in 1869, the first public health commissioner and statistical officer was appointed to the government of India, where they will be reporting to the Central Public Health Advisory. And by 1885, the local bodies, where the municipal boards and local boards were made responsible for sanitation. This is the period where Lord Ripon, who is considered as father of local administration in India, was the viceroy for India. And in 1896, the Indian Medical Service cadre was established. Unfortunately, after independence, there was no one to bag for this Indian Medical Service. So this got abolished by the time we got independence. Unlike the Indian Civil Service and Imperial Police, which transformed into Indian Administrative Service and Indian Police Service. And after the First World War, the 1919 Montagu-Chelmsford reforms, wherein the provincial governments established a dual form of government, that is diarchy, one at the center and one at the rural level. A rudimentary form of federalism was introduced, wherein public health, sanitation, vital statistics were transferred to the provisional government. And in the 1935 Government of India Act provided further provincial autonomy, wherein health becomes a state subject, and the Central Advisory Board constituted the All India Trainee. And by 1939, the Madras Public Health Act was the first comprehensive public health legislation in India, for which the modern day Tamil Nadu and Andhra Pradesh can be so proud of. So far, we have discussed about how public health was administered in British India. Now, we will see how sanitation, vaccination, vital statistics were done. So when Edward Jenner did in late 1790s, within the next couple of years, in Mumbai, the Superintendent General of Vaccination was appointed, and formal beginning of organized smallpox vaccination was done. And the sanitary commissioners were appointed in 1864, and the Birth and Death Registration Act, the first time was formed in 1873, and the recent one was done in 1969 after independence. So in the 1880, compulsory vaccination was introduced progressively in municipalities, and this act was one of the reasons why we see vaccine hesitancy, why we can attribute one of the reasons as vaccine hesitancy, because there was compulsory vaccination, and the British Raj see Indians as subjects, not as mere persons. So they didn't bother to persuade, they didn't bother to imaginative storytelling and convince the local population. Rather, they mandated it. And by 1881, the first census was taken, and in the 1880s, sanitary engineers focusing on water supply, drainage, and sewage were appointed. And by the early 1900s, vaccination program expanded. And now coming to how disease control, research, and training were happening in the British Raj. So the British people coming from the temperate zone, they have to invent a specialty called a tropical medicine, where they have to deal with the dreadful diseases like cholera, plague, malaria, leprosy. So they had their contribution in research as well as control from the 1800s to 1900s. And the last Epidemic Diseases Act enacted in 1897 was so old and still relevant because when Modi ji announced that lockdown, the powers, the Epidemic Diseases Prevention Act was invoked to ensure and enforce lockdown was done. So such was the legacy of British Raj. Now, in 1897, Ronald Rose discovered the transmission of completed the discovery of transmission of malaria cycle. After 5 years, he got Nobel Prize for that. And in 1909, within a couple of years, Central Malaria Board was established. And in 1911, the precursor of Indian Council of Medical Research, that is the Indian Research Fund Association, was established. And the National Institute of Nutrition, which is presently in Hyderabad, the precursor of it, the National Research Laboratory, was established in 1918. And this was the first time Indians got a recommended dietary allowance and what are the local foods that are eaten by the different sets of population was done in 1918. So this is the model that India inherited by the time of independence. So coming to the present model, it is deeply influenced by the British system, and most of the public health activities are managed by the state governments, where they perform the immunization program, vector control activities, entomological surveillance, MCH service, and health education campaigns. And the local body manages sanitation, waste disposal, street cleaning, sewage management, whereas the engineering departments like TWAD board in Tamil Nadu and other similar boards manage the water boards and other engineering related stuffs. So this created silos within silos. So this is the problem that the present day public health in India faces. So even within states, the public health responsibilities remain split. So public health was never housed within a single clear executive arm. The functions of public health were divided between Ministry of Health, Ministry of Water Resources, Food Safety Departments, which falls under Ministry of Consumer Affairs, and local bodies. The scatter also poses a very deep issue. And because of this, we are not able to position public health as a single national cohesive agenda, and this disjointness has a consequences. So now I will because of which public health, most of which is becoming a reactive rather than anticipating and prevention. I will give a small example. We have two research organizations in India, one which fights tobacco and the other one which promotes tobacco. So it will be very surprising, but I will just explain the detail. So Indian Council of Medical Research combats a disease against tobacco. Yet Indian Council of Agricultural Research has a central tobacco research institute in Rajamundry, whose main mandate is to promote the tobacco crops production as well as yield and to make sure that the tobacco farmers are profited. So because of this contraindication in vision, we see in India on public health, one hand tries to heal, the other hand tries to harm. So this problem results in poor response of public health. So this is the Indian Council of Medical Research Central Tobacco Research Institute situated in Rajamundry, Andhra Pradesh, and this is ICMR trying to fight against tobacco. And as you can see, the mandate of this is improvement in quality, value-added products, and also development of tobacco for domestic and exportable types. And this is the first of its kind of Asia. So this is what this ICAR Institute is doing. And recently, the name has been changed to National Institute of Research on Commercial Agriculture, wherein in addition to tobacco, they have decided to do turmeric, chili, castor, and ashwagandha also in research. So it took us almost 75 years to realize that in addition to tobacco, we have to improvise other crops also. The another important problem with regard to public health is its education itself, because the fragmentation lies in this one also. So the design and delivery of curriculum. So MPH curriculum in India mirror the same fragmentation of public health governance, that is scattered, uncoordinated, and lacking national standards. So the eligibility criteria varies. Some universities admit only MBBS doctors for pursuing MPH courses, whereas some universities admit any bachelor's degree without any common foundational baseline. And the course content is also very inconsistent. Some emphasize too much on theory, others too much on management and administrative prospects. Only very few offer technical depth or hands-on training. So, for example, when it comes to public health, we need core areas of public health engineering, how to know about water systems, waste management and drainage, nutrition and food safety, like food handling, food technology and FSSI linked skills, and behavioral sciences like behavioral change, social psychology, and social marketing. These are all hardly dealt with. And this 2 year program is overloaded with epidemiology, policy, health economics, behavioral science, and research, leading to superficial learning and inadequate mastery of these three things. And India lacks a dedicated public health cadre, unlike an IAS or IPS. And these MPH graduates often end up in short term projects or data entry roles in various ICMR projects, undermining the very purpose of their degree. And without technically strong public health workforce, India remains still vulnerable to antimicrobial resistance, climate-linked diseases, and future pandemics. That is why a national coordinated standardized MPH curriculum is required for epidemiology, surveillance, health technology assessment, environmental and occupational health, and policy analysis. And now, because of this scattered system, the public health is often reduced to a state subject in policy circles. But when you look at this thing, this does not reflect poorly. And in the constitution also, this is scattered. So who holds public health responsibility for public health in India? So this is $1 million question. When you look at the World Health Organization definition for public health, it says that public health aims to provide maximum benefit for larger number of people. So if you take this definition seriously, and then look at the Indian Constitution, you will find in the state list under Schedule 7 of the Constitution, entry number 6 will be public health. But if you look at a deeper look at the Constitution, you will find the definitions of public health will be scattered across union, state, and concurrent list, and public health is not exclusively a state subject. For example, take up union list in the Constitution under 7th schedule. Entry number 47 is insurance, which deals with health insurance. Entry number 50, establishment of standards of weight and measure. Entry number 55, regulation of labor and safety in mines and oil fields. Entry number 59, cultivation, manufacture, and sale for export of opium. Entry number 64, establishment of Institute of National Importance like AIMS, ICMR. Entry number 69, census. Entry number 81, interstate migration and interstate quarantine. Entry number 84, duties of excise and tobacco, though there is some modification post GST implementation. So these are all also very relevant for public health. We cannot say simply that these can be excluded from the purview of public health. Now coming to the state list. Though entry number 6 explicitly mentions public health, if you look at entry number 4, the prisons, reformatories, and bar stalls, they play an important role. Entry number 8, intoxicating liquors. Entry number 9, relief for the disabled and unemployable. Entry number 10, burial and cremation grounds. Entry number 14, agriculture, education, and research and protection against pest. This is very significant because it focuses about nutrition, pesticide exposure, zoonosis, and food safety. And more importantly, in the last 50 years, 70% of all the emerging and re-emerging diseases have zoonotic origin, including the recent COVID-19 pandemic. And in all likelihood, all the future pandemics will likely have a zoonotic origin. So this is quite important. And entry number 17, water supply, irrigation, canals, and drainage. Entry number 18, ponds and prevention of cattle trespass. Entry number 34, betting and gambling, where mental health is also a predominant part of public health. And excise on alcoholic liquors, opium, and narcotic drugs. Entry number 51. Now coming to concurrent list, where both the central government and the state government can manage. So entry number 5, marriage, divorce, minors, and adoption. So since demography is also a part of public health, we have to consider this also. Entry number 16, lunacy and mental deficiency. Entry number 17, prevention of cruelty, forest protection of wild animals and birds, since One Health, zoonotic spillover, climate-linked disease pattern, environmental health. All these aspects are under concurrent list, which is also a core function of public health. Then another important one, adulteration of foodstuffs and other goods, food safety, nutrition, and toxicity prevention. This also is a part of public health, but it is placed under the concurrent list. Entry number 19, drugs and poisons. We recently saw in Madhya Pradesh how innocent children has to die because there is a poor regulation on this part. Entry number 20, economic and social planning. Entry number 20A, population control and family planning. 23, social security and social influence. 24, welfare of labor. And most importantly, the current one that we are discussing, entry number 25, medical education. These all belong to the concurrent list, including entry number 30, vital statistics, which also deals with citizenship in addition to birth and death registration, mortality surveillance, and epidemiology. So when I have just summarized in this side, I'm not going to explain this in detail. So when you see this public health functions are constitutionally evenly distributed among union list, state list, and concurrent list. So present day in India, we don't have a nationally cohesive agenda. We don't know who is the authority and what is the problem with public health problem. And most of the things that we tend to do are mostly reactive in nature rather than anticipating and preventing and promoting public health, leading to increased life expectancy with lesser morbidity and mortality. Though we are quite successful in reducing the mortality, but we are not very successful in reducing the morbidity and the quality of life. When you include DALI and HALI, it has been not very happy numbers, and the numbers are very rockingly high, including the out of bucket expenditure. So this results in a fragmented public health governance between different layers of the government without coherent chain of command or common vision. And this is not accidental, but a colonial inheritance. So India maladopted much of its health structure from the British system, which is a unitary state. In Britain, we don't have states like Tamil Nadu, Kerala, Karnataka. That is a unitary state. While we are forming a federal state with three-tier nation, yet we, instead of following a US model, we followed the British model with a physician-centric focus. So what is the way forward? What are the future problems that I tend to see for public health in India? So in the coming decades, I believe that public health and global health will merge, and health threats will be increasingly transnational and borderless. Traditional and tech-driven risk will coexist, meaning the previously emerging diseases and new diseases like Nipah virus or Congo hemorrhagic fever or Marburg virus will be there, and tech-driven risk like internet addiction or porn addiction, both will coexist. And there has to be a shift from reactive to anticipatory system, and the digital and internet addiction will intensify. And there will be new biosecurity and pathogen risk, because this large language models are known to create new pathogens if it lies into the hands of non-state actors or terrorist groups. Then genomic revelation can bring down the cost and also drive precision in public health. But we need to focus about the antimicrobial crisis threatening the modern medical advances. Then migration and urbanization, accelerating the disease spread. This also has to be could be a future problem. And cross-cultural misinformation underlining public health programs. So this infodemics, this WhatsApp forwards, and many conspiracy theories being propagated through various social medias like Facebook or YouTube. This also is going to be a bigger headache and problem. And with the rise of technologies like deep fakes, there will be a very thin line between what is truth and what is unreal, even to the experts. So these are all the problems that I envision, along with the global mental health burden rising sharply. So what could be the solution? So back in 2017, when the government of India announced its national health policy, they promised to create a unified public health cadre by the year 2022. So even after 3 years, we are yet to see any unified public health cadre. And there has to be a shift in focus from mortality to morbidity reduction too. And we have to build an interdisciplinary cross-sectoral health workforce and strengthen the clinical and public health collaboration, and expand digital health analytics and surveillance, and enhance the global diplomacy and cooperation. And last but not the least, unless we make today, tertiary care is a very profitable business. That is why we tend to see a chain of corporate hospitals like Apollo, Malar Fortis, or any other group of hospitals that we tend to see. But we do not see a chain of sub-centers or a chain of primary health centers, because primary care or public health, they are not profitable. So we have to invent a new revenue model that make this public health sustainable, profitable, and more importantly, professionally rewarding for not just doctors, but all the public health experts who are involved in public health. So to conclude, public health means national building. And I want to end my presentation with the famous quote my professors used to say to me during my post-graduation. Whenever we ask, so during our post-graduation days, there has to be an internal assessment for every 6 months. So whenever we ask them what is the syllabus for this internal assessment, they used to say, everything under the sun is public health. So I just wanted to end the quote with everything under the sun is public health. And I started with the question, whether community medicine is equal to public health. So I leave it to you with an open-ended question, which you can fill up in the chat box. So what do you think, whether community medicine is equal to public health, or we have to increase the standards of public health in India? So with this, I conclude my presentation. And I wanted to acknowledge Dr. Swaminathan sir for adding me in the TMC case conference group, and Dr. Venkatesh Natarajan sir for offering me the opportunity to give a talk in this lecture series. And last but not the least, I wanted to thank and dedicate this to my teachers at AIMS Bhubaneswar. So thank you, and open to questions.
Thank you, Dr. Aravinda. It was a short and terse and covered many grounds as far as public health is concerned, and especially kind of allowed us to understand that community medicine and public health are not the same, and that clinical medicine is not the same as public health. And to start the proceedings, let me pose this question to you. One of the
Yes,
important aspects of proper public health is funding.
yes,
So
sir.
you need to fund the process. So when it comes to funding, poor nations really struggle to build a cohesive national model. And considering the different healthcare models, like the beverage model, which is being followed in Britain, where a nationalized healthcare system is present, and if you take the American model, which is a mixed match of many things, and if you take Germany, you have the Bismarckian model, where it's insurance based, but both the patients as well as the employer and employee both have to contribute for the betterment of the community. What kind of a model do you think would be appropriate for India? Whether we are increasingly moving away towards healthcare provision through insurance-based kind of model, and in that kind of a scenario, um, how would you expect public health to be funded? Would it should it come from private hands, or it should come predominantly owned by the government?
Sir, as far as the models are concerned, whatever the model that we tend to often quote, like the NHS model of UK or the USA model or even Germany model, I would not say that one specific model to be ideal or very perfect, because even those nations are also struggling with how to make things or customize things for their own needs. And when you take a country like India, where you still see diseases like tuberculosis as well as diabetes, and you see diseases in all the spectrum, like starting from hunger-related deaths to degenerative diseases or protein misfolding problems. So I feel like, uh, as far as India is concerned, one idea that I will propose is, where management professor Dr. C.K. Prahalad has advocated. So what it is like, we have to create a model in such a way that the running down of hospital itself is quite profitable in nature. Meaning, we have to make a health system in such a way that we will be able to charge the rich patients, and from the rich patients we will be able to provide services at free of cost for poor patients. For example, if you take the Arvind eye care systems, they almost run on this phenomenon. And important another aspect I would suggest is, when it comes another aspect of this is, when it comes to public health, there are a lot of competitors, because when you have a tobacco company actively persuading the adolescents to go for addiction, or the state governments itself running liquor companies, there are a lot of competing interests. So first we have to plug the easily pluggable solutions, and then we have to go for in the tertiary care solutions, which is like a NHS or insurance model. So when it comes to public health or advocating public health, I would suggest we have to think in ways wherein a person does not even require a hospital in the first place. We have to catch them if you are able to frame a system in such a way that reducing the patients in itself, reducing the patients rather than treating the patients with effective solutions. That would be the ideal model for a country like India, sir, with a per capita income of roughly $2,000.
Yeah, you are advocating for a unified central national cadre in public health.
Yes,
Am I
sir.
right?
Yes,
So
sir.
if you have something on the lines of civil services, right?
So not exactly civil services, sir, because I'm not a big fan of bureaucracy and red tapeism, which is quite
Mhm.
prevalent in our country. What I feel is like, even if there is a problem, sir, let's say that there is a very rare heart operation that has to be done. We at least have the manpower. At least there will be some 50 to 100 surgeons that who will be available in India to do that surgery. We have that in-house capacity. But what I feel is like in India, we don't even have the capacity to manage or tackle public health problems. So if you ask me how to construct a sewage treatment plant, or what are all the things to look in for a sewage treatment plant, to whether it is working correctly or not, I do not know. An engineer might know, but that particular engineer might not know how the sewage treatment plant is effective in preventing the diseases. He might be knowing the engineering aspect of it. So what I'm advocating is we have to at least create a set of professionals who is competent in this interdisciplinary and multidisciplinary field, so that they know something about everything of this public health. So only when we have a technical cadre, then we can think about a bureaucracy and managing this. We currently lack even the technical cadre, sir.
If there are any questions, I think audience can unmute themselves and ask Dr. Aravinda directly.
Hello, sir.
Yes, sir. Yes, ma'am.
Yeah, I'm Dr. Jnanapriya. I work in a Tamil Nadu government public health and as a PhD medical officer. That was very insightful. Your class was awesome. Uh,
Thank you, ma'am.
as you have highlighted, the technical details we do not know. So it will be, I mean, like to enhance whatever your vision was, it will be much better. Somebody who has worked in public health for so many years, you give them better knowledge and make understand them better and devise a plan to that. As you said, it is level manned at block levels, right? So you create
Yes,
a cadre at block levels and make them work for that block, because as you said, India is very federal nation. So the problem which exists in this block may not be even there in the other block.
true,
The
ma'am.
diseases which I see may not be even seen by the doctor sitting in some other block. So it has to be individualized, as you said, and a technical cadre has to be created, and it should be rewarding, as you said. But I differ with you in one point that running a public health setup to be profitable, that may not be a ideal thing in my view. I see. What I think is government has to take a responsibility, and it may have some it can run on some incentives, like if you like public private partnerships, that would maybe help better in my view, because being present in the local place, they have that much responsibility, like the CSR initiative like things, even that could help to some extent. And government should own the primary care model. That I have no second thought about it, because once it becomes profitable, then it becomes a business, right, sir? So when
Yes,
it
ma'am.
becomes a business, there is no morality to be seen. That is how business is. Business with moralities don't survive in a longer
Yes, ma'am.
run. So your talk was very insightful, and being in a system where the public health is of good standards, I see your vision to take it to next higher standards, and I hope people like you make it reality someday, so that we all will enjoy the fruits of it. And what, as you said, preventing the patient from becoming a patient is the best idea, as you said, and that was very nice of you, sir. And thank you for this lovely presentation, I should say.
Yes,
Because it
ma'am.
needs a lot of commitment from somebody to talk such a dry subject, I would say. I mean, as perceived by many of them. Because
Yes, ma'am.
as a person, I don't see it as a dry subject, but a lot of people perceive it so. So, having chosen this, kudos to you, sir. Thank you. That was nice class. And I have no doubts as such. I wanted to give a credit to you. That's why I spoke. Thank you so much.
Thank you for your kind words, ma'am. Actually, the topic was suggested by Dr. Venkatesh, sir. So, sir, credit has to be given to sir. And to add on
Okay.
the point that you have said, when I meant about profit, I'm not saying about inviting a private players into this, ma'am. The government itself, I'm saying, if you take up the government ventures itself, currently the liquor selling business is at profit, so the government is now trying to make as much as profitable it wants, and it concentrates more. So when a government owns something and it is profitable, the government will give more attention. In that sense, I am saying, ma'am. So one example that I can give you is I recently authored with one of my students. So if you take up insulin injections, so insulin injection in India, we have roughly 15 million, that is 1.4, 1.5 crores of diabetes patient, of which 10% will use insulin at any given point of time. And insulin syringes are used only 3 to 4 times. Beyond that, we have to dispose. And by this alone, we are generating close to around 10 crore insulin injections every single week. 30 crore insulin injections every single week. And this insulin, the research and the design of these insulin injections are very much done mostly by multinational pharmaceuticals. And their concentration is on reducing the gauge of the needle from 33 gauge to 34 gauge, so that the pain perception is reduced. But none of the pharmaceuticals are concentrating on devising an insulin syringe that can long last at least for a year or even for a month, which will reduce the load. We have technology where we have institutes, we have departments like material science department in IASC or IITs, where they can devise a needle which can long last. But only government can do that. And if government does that, they can take all the patents. This will remain profitable. And from this profit, they will be able to subsidize the medicines or whatsoever that could be possible. So when I meant about profit, I am talking about government raking profits. I just want to give the example of railways. So we have a first class AC as well as unreserved compartment. If you go to Tamil Nadu, if you use Tamil Nadu Express to reach Delhi, the purpose is solved whichever compartment you use. But a passenger in first class pays much higher than a unreserved passenger. Though technically railways is not so much profitable, but I'm just saying we can emulate such model where we can charge premium in our own government hospitals and use that premium to subsidize and also for providing better quality of care for poor patients. So when I meant about profit, I'm not trying to say that we have to invite private players. I want to say that we have to invent some new revenue models for the government for providing services in public health.
Okay, sir. Yeah, I get your point now. Okay.
Yes, thank you.
Thank you, sir.
Sir, I'm Dr. Uma Kalyani.
Yes, ma'am.
That was a very good talk, sir. I enjoyed your talk. You covered
Thank you.
comprehensively everything about public health, and that example about tobacco, I really when that drove your point home. My actually sitting in a tertiary care, I can see for want of a good health education, how much people land with say diabetic foot ulcer, with going for amputation. Those things which can be prevented by a good education, which is mostly a public health, it comes under public health purview. I think the problem is sometimes ago we had to meet some secretary level people to submit a proposal. In geriatric, we had to prevent this frailty, those things, so that we'll prevent future fractures, falls, etc. But they don't understand. They say it's a useless thing to do prevention sort of things. So I think we should do more study, cost analysis study, like you prevent one falls or fracture, how much you save in the healthcare, subsequent hospitalization, those things. Do we have any cost analysis study like that done here? I mean, we see more such studies in West, so that these things can be, these points can be driven home. As you said, this prevention part of thing in public health. But I don't see much of those studies done in India. What's your point on that?
Yes, ma'am. Cost of illness study or any cost benefit or cost utility study are not done, and not done very frequently. And for some diseases, health economists do such studies. And the problem is, even when we tend to do such a study, the policymakers are not interested in taking up taking up that seriously, ma'am. Because if I tend to say that by investing 1 rupee in women's health, it will yield 30 rupees for me, nobody is because it is not a vote catching scheme. If I tend to say that if I appoint more village health nurses, or if I appoint more doctors at the primary healthcare level, because currently the vacancy is around 25%. Recently, the medical recruitment board in our state itself has advertised for 1,100 doctors post, meaning that is 1,100 doctors are vacant. So in this case, I don't think we can convince the policymakers, because these are all not populist schemes, ma'am. Rather than, they are very happy to roll out any cash-based incentives on economic lines. So the problem with this is mindset, as well as attaching the populist schemes to what is it, ma'am? Election manifesto. So we have, whether we like, we might boost that we are the third largest economy, but when it comes to per capita income, we are not so, ma'am. So we have got only little money to spend, and those little money, the policymakers are not ready to spend for a future anticipated thing. Rather than, they wanted to get instant benefit. No minister or no politician can take benefit that you are not having typhoid today, so you vote me because I introduced a typhoid vaccine. Rather than, they will be happy to say that I gave you saris, or I gave you rice bags, or I gave you this gift, so vote for me, and people will also be happy. So this, since this tangible part is missing, I think policymakers are very hesitant to undertake this one.
Thank you, sir. Well put. Thank you.
Thank you, ma'am.
Are there any more comments or questions?
சார், இந்த மக்களை நான் டாக்டர் காயத்ரி பேசுறேன், சரையோ காயத்ரி. இந்த மக்களை தேடி மருத்துவம் திட்டம் சொல்லிட்டு வீட்டுக்கு போய் டேப்லெட்ஸ் கொடுக்கறதுனால கம்ப்ளைன்ஸ் வந்து ரொம்ப கம்மியாகுது. அதை நீங்க ஃபீல் பண்றீங்களா? வாட் ஆர் யுவர் ஒப்பீனியன் அபவுட் தட்?
ஆக்சுவலா இட்ஸ் மிக்சடு திங், மேம். மக்களை தேடி மருத்துவம்ல கம்ப்ளைண்ட்ஸ் கம்மியாகிறது உண்மைதான், மேம். Another aspect of it is there are a lot of bedridden patients who can never come to the hospitals, who actually need palliative care. And மக்களை தேடி மருத்துவம்ல we have recognized palliative care as a component. So இது இந்த மாதிரி ஒரு லார்ஜ் ஸ்கேல் ப்ரோக்ராம் ரோல் அவுட் பண்ணக்குள்ள என்ன ப்ராப்ளம் வருதுன்னா, ஒவ்வொரு ஏரியாவிலையும் ஒவ்வொரு மாதிரி ப்ராப்ளம் வருது. பட் அன்பார்ச்சுனேட்லி whenever such schemes are rolled out, we get a very uniformed guidelines from the state headquarters. ஸோ அதனால வந்து கம்ப்ளைண்ட்ஸ் வந்து போர் ஆகுறதும் உண்மைதான். ஆனா ரீச்சிங் த அன்ரீச்டு, ஸோ அன்ரீச் ஆகாத பாப்புலேஷனுக்கு நம்ம ரீச் ஆகுறதும் நடக்குது. ஸோ லைக் போத் குட் அண்ட் பேட், லைக் ஜஸ்ட் செல்போன்ஸ் இஸ் ஆக்சுவலி ஃபார் குட் as well as பேட் மாதிரி இதுவும் நடக்குது. இதுல இன்னும் ஒரு சில பிளாக் மெடிக்கல் ஆஃபீஸர்ஸ் they told me that and the women health volunteers they are now getting upgraded as quacks. Now they start prescribing medicines. So இந்த மாதிரிலாம் வந்து நடக்குதுன்னு சொல்றாங்க. பட் at the same time elderly people, orphanated old ladies, they are able to get medicines which they otherwise would not have in their doorsteps. So both good and bad are there, ma'am.
பட் அதோட பர்சன்டேஜ் வந்து எவ்வளவு இருக்கும் சார்? ஒரு மேபி ஒரு 5 to 10%
அது ஸ்டடி பண்ணாதான் தெரியும், மேம். அனிக்டோடல் எவிடன்சஸ் வச்சு, அதுவும் ஸ்டடி பண்ணாலும் ஒவ்வொரு பிளாக்குக்கும் டிஸ்ட்ரிக்ட்டுக்கும் மாறிக்கிட்டே இருக்கும், மேம். அனிக்டோடல் எவிடன்ஸ் வச்சு பெருசா சொல்ல முடியாது.
So number of bedridden patients per block or per PHC.
Yes, ma'am. Even if not bedridden, நான் ஒரு தடவை பேசிட்டு இருந்தப்போ ஒரு கேப் டிரைவர்கிட்ட பேசிட்டு இருந்தேன். he was telling that he used to get medicines at his home. அவர் வந்து மாசத்துக்கு ஒரு 2-3 தடவை தான் வீட்டுக்கு போவாங்க. it was like a cooperative cab. so அந்த டிரைவர் வந்து what he said was like he don't have அதாவது அவரோட ஒர்க்கிங் பேட்டர்னும் ஹாஸ்பிட்டலோட டியூட்டி டைமும் மேட்ச் ஆகாது. ஸோ இட் இஸ் யூஸ்ஃபுல் ஃபார் ஹிம். ஸோ இட் இஸ் நாட் அபவுட் ஒன்லி பேரலிட்டிக் patient who are bedridden getting benefited. People like him are also getting benefit. But what you said, the problem exists, ma'am, and the burden of the problem, அதுக்கான solution வந்து it is very complicated. burden கூட நம்ம மெஷர் பண்ணிடலாம், பட் சொல்யூஷன் வந்து even I'm also not competent enough, or at least as of now I don't have any solution for this.
அட்லீஸ்ட் அது உங்க இண்டிவிஜுவலோட ரெஸ்பான்சிபிலிட்டி. அவங்க வந்து 3 months once FPS, PPPS and PP வந்து ஒரு முறை மெடிக்கல் ஆஃபீஸரை பார்த்துக்கிறது அவங்களுக்கு பெட்டரா இருக்கும்.
Yes, ma'am. இதுக்கு வந்து what we can do is we can appoint a dedicated diabetic educator. CMC Vellurla they have such a designated cadre called diabetic educators, where they will undergo a training for 1 year regarding how to give education in diabetes. So they are like they will be able to give counseling for primary, secondary, tertiary prevention, dietary counseling, and they do regularly follow up. So அது மாதிரி டாக்டர்ஸ் எல்லாத்தையும் பண்ணிட்டு இருக்க முடியும். ஏற்கனவே மெடிக்கல் ஆஃபீஸர்ஸ்க்கு அவ்வளோ பர்டன் இருக்கு. ஸோ ஐ டோன்ட் திங்க் டாக்டர்ஸ் would be able to give them, but unless we establish at least ஒரு நீங்க சொல்ற மாதிரி ஒரு மாசத்துக்கு ஒரு தடவை யாராவது நம்ம சிஸ்டத்துல இருந்து கால் பண்ணி வரீங்களாமா, எப்ப வரீங்க, உங்களுக்கு என்ன ஆச்சு, நீங்க பாத்துக்கோங்க அப்படின்னு சொன்னா the complaints will be much better as you suggested, but I don't think doctors would be able to do so.
ஓகே சார்.
இல்லைன்னா நம்ம எழுதுற மாதிரி கணக்கு காமிச்சு நம்ம ரிப்போர்ட் தான் போடுவாங்க, வெளியே பேசுவாங்களான்னு தெரியாது மேம்.
இல்ல இது லைக் 3 months once மட்டும் பிஹெச் விசிட் பண்ணோம், அப்பதான் வந்து நெக்ஸ்ட் மந்த்ஸ் ட்ரக் கொடுப்போம் அப்படின்னு ஒரு
எஸ் மேம். 3 months once அவங்க வர்றப்போ டாக்டரை பார்க்கணும், அதை என்ஷூர் பண்ணலாம். பட் அதை சொல்றதுக்கு we need a separate cadre like diabetic educator like CMC has.
ஓகே சார்.
Thank you, ma'am.
Sir, according to you, which state has a better public health model? Do you have any idea about this?
Ma'am, every state has its own pros and cons, but when it comes to numbers, I mean, when we tend to see through numbers, Kerala and Tamil Nadu fares much better than the rest of India, but other states also quietly catching up. States like Karnataka, Maharashtra, Telangana, after the bifurcation from Andhra Pradesh are catching up, ma'am. And rich states like Delhi, they are also quite doing good. And excellent in பாத்தீங்கன்னா கோவாவை சொல்லலாம், பட் கோவா வந்து தமிழ்நாட்டோட ஒரு 2 டிஸ்ட்ரிக்ட்டுக்கு ஒரு டிஸ்ட்ரிக்ட் சொல்லலாம், மொத்த பாப்புலேஷன் ஒரு 30 லட்சம் தான் இருக்கும். ஸோ அதனால ஸ்டேட்ஸை கேட்டகரைஸ் ரேங்கிங்னு போடுறதே கொஞ்சம் நிறைய இஃப்ஸ் அண்ட் பட்ஸோட தான் சேர்த்து போடுற மாதிரி இருக்கும். பட் இன் ஜெனரல் வி கேன் சே சதர்ன் ஸ்டேட்ஸ் ஆர் பெர்ஃபார்மிங் ஃபேர்லி குட், மேம்.
Dr. Aravinda, one of the problems in our country is the relative lack of national registries.
Yes,
so
sir.
we don't have national registries for CKD, we don't have national registries for transplant patients, we don't have national registries for diabetes, hypertension, or for a majority of these comorbidities. And being a very complex, diverse, culturally diverse, and with different language ethnicities, a centralized solution is not going to help us. So a guideline from a centralized institution and a proposal to create a model that integrates care at the level of the periphery is probably more important to us. As you said,
Yes,
for example, the state government itself is struggling. It gives a uniform code and every block seems to have a different set of problems. And
Yes,
there is no leeway or there is no flexibility in how these problems can be handled at the block level. So you need to have imaginative, creative individuals who can understand the notion or the goal of a uniform implementation. At the same time, they should have the ability to flex it in the way that the goals are achieved, depending upon local requirements.
Yes,
so that seems to be the biggest challenge that we face today. And there is huge paucity of research in terms of research output, in terms of understanding basic illness, etc. We borrow Western data for most of our and extrapolate to the Indian population, or we borrow from Western studies that have looked into Indians and we make use of that. While the expenditure in terms of GDP is just hovering below 2% all the time, and health not being a fundamental right, and education not being a fundamental right in this country, I think it is apt to say that creating a national level public health cadre with uniform training in an MPH is probably the first step that could address most of these issues. Could be the most of these issues. That's the kind of the carry-on message that take from your talk.
Yes, sir. Yes, sir. I agree with what you said, most of which, sir. Like as far as creating registries are concerned, I just want to add up that as of now, whatever the registries that we tend to maintain, most of which are kind of most of the health workforce see this as a kind of punishment or extra work burden, sir. So one thing is, if we tend to incentivize, let's say that if you tend to identify a cancer and upload it in the registry, we will pay you X amount of rupees. That could help it, sir. But again, there could be a lot of false entries or extra number of entries, which we also have to be wary of, sir. So that is another problem we tend to have with these registries, whether it is cancer registries or rare disease registries Or for example, if you take up the case of rare diseases registry, the government of India maintains a dedicated website, and the government is also willing to provide assistance through financial funding as well as through other means for those patients. Yet, when it comes to any rare inborn errors of metabolism or very rare genetic syndromes, not even 30,000 has been reported. So even though we estimate it to be around 50 lakhs for a population of 145 plus crores of population, we not even have got 30,000 registrations filled up even by the well educated parents. So there is lack of awareness. Even if there is if the government is ready to provide funding, the execution of that funding itself has been marred with red tapeism and bureaucratic hurdles. So the problem is we need to have a cultural shift also along with whatever we aspire for, sir. When it comes to research ecosystem, we don't have the culture of research in the first place. Even let's say that tomorrow, if the government of India decides and gives 200 crores to me, I don't even know how to spend that 200 crores and do research. So, or even if I tend to know how to do this how to spend this 200 crores and execute a research, as an independent person, I cannot do so. I need a team of people and an ecosystem, and that ecosystem is also missing at the grassroots level. By grassroots level, I mean institutions like Tanjore Medical College or Madurai Medical College or even Madras Medical College. I would say so, sir.
But to end on a positive note, I guess things are changing. We are increasingly seeing a lot
Yes,
of
sir.
publications of good standards, especially people are publishing in Nature and Lancet, especially from MMC. There were 2 recent papers, and
Yes, sir.
there are quite
In
a lot of
nephrology.
in nephrology. Yeah.
Yes, sir.
The ICMR is doing a great job. The India Dive
Yes, sir.
study is one case in example where the kind of data that has come out is real world data is extremely useful for us to understand both the burden and in terms of prevention. And there is an interesting comment by Dr. Nitish. Dr. Nitish, would you like to unmute yourself and speak out your opinion? Dr. Nitish, are you there? Okay, let me read it from the chat box.
Yes, sir, I'm able to read it, sir. He's saying centralization and mandatory usage of electronic medical records should give a major advantage. And already ABA card is used, but not generalized and made mandatory. Sir, I agree with this point completely. The issue is we have to make sure that privacy concerns and data leakage is not there, and we have to make it. If we are quite successful, I believe that in the next decade, we will be using this unified health interface on par with just like now how we are using unified payment interface. So this is a very positive aspect of this, and I completely agree with this ABA ID and other parts, sir. I believe in possibly in the next decade or so, if you are able to have unique IDs, we will be able to make better decisions with the data that is generated through these unique IDs.
If there are no further questions or comments, I think we can probably end the session. So, Dr. Aravinda, thanks for an excellent, although you're not an alumni of TMC, and you have become a TMCN now, and you're taking care of the TMC wards. The graduates who are going to come out of your mentoring are going to be really very lucky. So, thank you for giving us your time and a wonderful lecture, and it kind of set right a lot of important concepts, and it also has equally raised very important questions. And to end with Rudolf Virchow's quote, medicine is a social science and politics is medicine writ large. So you didn't see the difference. And in your definition, one of the important aspects of public health, although you put it as even politics, I think most of our problem starts from there.
Yes, sir.
Thank you so much. Thank you all of you for attending. And the recording of this particular talk will be available and it will be uploaded as early as possible. And I thank Dr. Aravinda once again for giving his time and expertise to us. Thank you.
Thank you, sir. Thank you for inviting me, sir. Thank you, sir. Very grateful for the invite. Thank you.